LTACs, or long-term acute care facilities, are kind of subacute ICUs. Most of the folks that go to those are individuals that have a tracheostomy and are on chronic ventilator use with potential for weaning. Sometimes it's more complex. Within the hospital, there's acute rehab. Usually, these are reserved for post-stroke patients. But if you have an older adult that has multiple comorbidities, high medical complexity, and can endure 3 hours a day of rehab, that individual might qualify for acute inpatient rehabilitation. It's important to hone in on the medication regimen. Upon discharge, it's important to indicate what each medication is for and the other stop dates. If you've prescribed an antipsychotic for delirium, you have to have a stop date for that, for either weaning or a stop date. Due to Medicare rules, nursing homes will no longer accept PRN medications. If you have a tapering schedule, it's important to make sure that the transfer note indicates that discharge planning is a good point for targeting medications for deprescription. Those include NSAIDs and proton pump inhibitors, which over the long run cause reduction in bone quality and can predispose individuals to acquiring C. diff colitis if they're on antibiotics laxatives, unless they're on chronic opioids. Sleepers are the bane of long-term care and community care too. Any of the Ambiens or the Lunestas are all associated with increased fall rates. It's important to document clearly the medications that are new. If there's any side effects, those are going to be the ones that are most suspect for creating a medication side effect. You want to avoid the medication symptom cascade. If somebody got started or escalated on their antidepressant medication and SSRI and are complaining of loose bowels or diarrhea, and then all of a sudden they get put on a little Paramite or some anticholinergic, they become more confused or have behavioral changes and so forth. It becomes a situation of a dog chasing its tail, using one medication to treat the symptoms of another. It's so important to educate both patients and caregivers when going home. It's important to let the patient know what their follow-up appointments are and to alert them to any warning signs. You don't want to overstress the patient and the family, but you want to give them some parameters or guidelines for what to watch out for, as well as self-monitoring, whether they're monitoring oxygen, weight, and heart failure situations. These are well-placed instructional opportunities for self-efficacy in chronic disease management. It's also important to identify which referrals you've made. The discharged patient should be seen from the community setting within 7 days of hospitalization. They usually say 7 to 10 days, but the sooner the better. When the patient is discharged to another setting, such as skilled nursing facilities, they should know the nature of the new institution, what their strengths and weaknesses are, what they can expect, as well as who will be following the patient. Technically, in any nursing home setting, the primary care provider of record should follow the patient into the long-term care setting. A lot of times, primary care providers don't have either the time, ability, or interest, so only 1 out of 3 doctors have actually set foot in a nursing home in the primary care arena. We know that the vast majority of physicians do not go to nursing homes. This means that the older adult that's been transferred there will have a new doctor, a new face, new provider, which may be a physician extender, a physician's assistant, or a nurse practitioner. It creates a whole new gap in understanding expectations that needs to be addressed. It's important to communicate with the primary care provider. Some of the information that you want to convey are pending studies or some of the nuances of goals. For example, this patient was doing well until they had intermittent chest pain, and then they wound up getting treated for an incipient coronary artery disease that was discovered during hospitalization, but now they're emotionally crippled because they're afraid they're going to have a heart attack if they do any rehab. Dealing with those psychological overlays may be an important nuance of care, rather than just referring to a nursing home for physical therapy. If you're the nursing home provider, you might want to order psychologists to evaluate the patient for cognitive behavioral training or any other types of interventions that might help in that transition of what's equivalent to a post-traumatic stress syndrome. In terms of the promptness of the discharge summary, it's highly recommended that the discharge summary include the 4 M's. If you can evaluate what matters to the patient, what are their goals, the medications, the reconciliation, and what was deprescribed. The other 4M is mentation. Are they still delirious? Have you done the confusion assessment method? Prior to discharge, have they had a mental status check with the St. Louis University mental status tool? Are they depressed? Was there a PHQ-2 screening? And so forth. It's also important to know what the mobility goal is of the individual. We also want to talk about methodology for improved transitions of care around quality improvement efforts. To assist with that is the prototypical plan Do Study Act cycle. These are called PDSA cycles of rapid change. You want to look at the medical literature and say this is a nurse visit program post-hospitalization. Is that better than what we're doing currently? Or can we create a post-discharge health coach? Should that health coach be within the patient-centered medical home? Or should it be a standalone post-discharge care coach? These are some of the questions that you might want to dig into the medical literature and say we want to apply this particular change in our system and see if it works. Then you do the change idea, you implement it, you test it over a period of just a few weeks, a month to 6 weeks, and then you study it. You collect the data. For example, if your primary goal is in transitions of care to reduce rehospitalization rate, that would be one of the forms of the data that you'd want to collect. Then you look at the data and say by doing a home visit program and including a health coach in our transition of care process, that we found a 1% decline in rehospitalization rates. Maybe it's working pretty good for us and is reasonable, so we're going to adopt this intervention. That's how quality improvement works, and hopefully you're familiarized with that process. For example, the Institute for Healthcare Improvement is looking at specific goals. Let's say you just want to do a process improvement. That would be the percent of improvement in communication with primary care providers, which may be not only a written, but a verbal communication, so that might be your metric. The other metric may be better. Medication reconciliation at the point of transfer. You can see, for example, whether a pharmacy consultant improved medication reconciliation. The percent documentation of older adults of their geriatric 4 M's. That harkens back to the Rush Medical Center study, which showed that by doing this in the hospital setting, you can reduce future length of stay by nearly 1 full day. In summary, we know that older adults transitioning across healthcare are at risk for suboptimal care and AES, or the adverse events. We also know that successful transitions can result in more effective care plans. They can reduce the adverse events, and they will also importantly increase functional recovery. To optimize the transitions of care, we want to enhance care coordination, discharge planning, and case management. If you have a geriatrics program, incorporating the geriatric team into this process would really serve the healthcare system well. The other point for an optimal discharge is medication reconciliation. Here are 3 steps that could be used for transitions of care. The first one is a set of expectations for the provider teams and both ends of the primary care and hospitals. What are the expectations for communication? Is it only going to be written communication alone? Will it be written and verbal communication? Based upon some parameters, and those need to be, when I say established as a policy, you want to tailor the communication strategies to the type of transition. For example, if somebody's going to home care, it would be important for somebody from the hospital-based team to communicate with the home care nurse to explain what your expectations are, what the problems are. And that would be very different for somebody that's being discharged home with a direct referral to their primary care providers. You might want to alert the primary care provider. This person's recovering from acute heart failure, and it would be great if your team could give them a call in 2 to 3 days to see if they're gaining any weight. Finally, we want to improve care transitions by using quality improvement with both regional and national metrics. For example, the emergency room use, the rehospitalization rate in 30 days, or rehospitalization rate in 90 days. These are all metrics that are obtainable. You can work with your quality improvement department to establish those metrics and then compare your patient panels to those metrics. Start small. If you want to start with one small primary care practice and then start including 3 or 4 primary care practices, you build your data set to see if what you're doing through your quality improvement is really having an impact. That's the conclusion of this presentation series on transitions of care. The inclusion of geriatric teams is extremely valuable and probably the most impactful strategy for enhancing transitions from acute care to the other settings. Thank you for your attention.